Okay, Monica, back to you.
Thank you very much, Scotty. And we all now are waiting for the presentation of Dr. Christine Pan, who is already here with us. And I would like to introduce this awesome woman. After you heard Catherine Pettis saying how important is palliative care around the world, I hope that you have understood, my dear colleague, that you are not alone here in your mission in where you are here in Canada. Palliative care is everyone's business, as Dr. Christine Pan is going to tell you right now. It's all over the world. We are millions of good-hearted people doing fantastic things every day without having any kind of publicity, right? So I hope you enjoy this marvelous workshop that Dr. Christine Pan is going to present us. Palliative care, it's everyone's business, and it's all about sustaining qualitative care amidst change. Christine, it's with you now.
Thank you so much, Monica, and thank you so much for having me. I am truly honored and humbled to be here to share this talk with you. As I begin, I would like to respectfully acknowledge that we are on the homelands of the First Nations and Métis people. We're presenting to you today from the traditional territory of the Anishinaabe Nation, specifically the Nipissing First Nation. Understanding that each of us may be participating from a different location, I invite you to think about the territory that you are tuning in from and recognize the contribution that Métis, Inuit, and other Indigenous people have made in shaping and strengthening our communities and our province and country as a whole. I would also like to acknowledge some people that have helped me with this talk. Dr. Incardona, Dr. Myers, and Dr. Steinberg's group have done a lot of work on person-centered decision-making through the HPCO Healthcare Consent and Advanced Care Planning Working Group, and I've used some and adapted some of their slides here. In our own area, the Health Sciences North and Northern Advanced Care Planning Goals of Care Education team has also helped me a lot. And of course, there's all the palliative care providers who are in Sudbury, in the Northeastern Ontario region, that have always inspired me and helped me through learning and being able to then accumulate all my knowledge that I'm hoping to share some of that with you today. And all the patients, families, friends, and colleagues who, again, we're all in it together, like Monica said, and being able to be part of this team has really inspired me to continue what I'm doing. I don't have any conflict of interest to declare for this talk. And for our learning objectives today, I'm really trying to, again, reinforce the fact that we are all doing this together and palliative care is everyone's business. I'm hoping to encourage everyone to reflect on and increase your comfort level and confidence in your role by covering the 3 areas in the talk today. Firstly, I want to discuss the palliative care approach and highlight how it has really evolved over time. Then I'll cover the work that HPCO has done on person-centered decision-making. So this work is really done in order to make sure that what we're doing is compliant with the Ontario legal framework. But the approach itself is really applicable regardless of where you are, whether you're in Ontario, somewhere else in Canada, or even internationally, because it is a person-centered approach. And really, it can be applied to all aspects of healthcare. I'll also be sharing with you some of the recent strategies that our palliative care teams in Northeastern Ontario have employed to deliver palliative care to sustain the quality care that we all have been doing during and beyond the pandemic. So let's start off with the palliative care approach. I kind of started out with the palliative care definition with the WHO. I think a lot of you may be familiar with it. And there's a lot of words on this slide. I don't really expect you to be reading all of that, but I think a lot of it actually resonates with all of us. It speaks to palliative care being an approach to care. It speaks to our focus on quality of life and affirming life itself, which is very interesting because whenever people talk about palliative care, they think about death and dying, and really a lot of what we do is about living and how we make the most out of life and living. We also normalize death though in the meantime because like one of my colleagues always say, death should never be a medical event. It is part of life, is a social event, is what brings us together, just like birth and other events in our lives. We are here to support patients and families, and we are part of the team, and that's the part that I love the most about palliative care. And the last part that is really highlighted here is that palliative care is applicable to early on in the course of the disease or the illness journey, and this is what has been really evolving over time, and I'll be elaborating more on these aspects. So, as we all know, palliative care is really not limited to any single setting. It happens across sector, and as providers, we strive to provide seamless transition for patients across these sectors. The formation of the Ontario health teams share the same vision, and it is really important for us to make sure that palliative care is going to be integrated in each and every one of our Ontario health teams in this new care delivery model. Similarly, sorry, I'm just going to make sure this works. There we go. Similarly, the WHO has highlighted the need for palliative care at all levels of care, including primary care, secondary care, as well as tertiary care. So this model is probably familiar to quite a few of you, and it speaks to the fact that even though some of us will identify ourselves as the specialist in palliative care and being a part of a focused palliative care team, really, at the end of the day, 100% of our patients will die. So the provision of palliative care really is done by everybody, and only a few of the patients will need specialist level palliative care. And this is why we all focus on this palliative care approach to try and ensure that all the providers are going to be comfortable with it so that all our patients can benefit from it. So when we are talking about the palliative care approach, I think a lot of you have seen some version of this. So what we're really talking about is early identification of patients who might benefit from the palliative care approach. We're talking about assessing the current and anticipating the future needs of patients, as well as the family and caregivers. And this should be done across all domains of care. And then we are talking about managing and planning collaboratively with our team and our patient, family, and caregivers to address these needs. So let's start off with thinking about the early identification, thinking about who might actually benefit from palliative care approach. So I have a few examples here. The first one is Mrs. Ava Smith, or S. She's an 86-year-old female with mild dementia. She has a very, very tight heart valve that's really stopping the blood from flowing out, and that's why she's experiencing chest pain and shortness of breath on exertion. At this point, though, because of her frailty and the complexity of surgery, they have decided not to have surgery. So if you reflect on it, do you think this patient will actually benefit from a palliative care approach? Next person is Mrs. Lucy A. She's a 63-year-old female who has just been diagnosed with lung cancer, and they found that the cancer has already spread to her lymph nodes in the chest. She's waiting for the oncologist to see her and trying to figure out what treatment she can actually get. Would you initiate palliative care approach in this person? The last patient is Mr. Ma. He is 70 years old. He has advanced COPD. His lung function is only 30% of normal. And he's recently been admitted to the hospital, not quite needing to be on a ventilator, but on the BiPAP machine. He is, even though he's recovered enough, he's still getting shortness of breath even when he tries to do anything. So if you look back at all three of these patients, you can probably figure that all of them can actually use an initiation of a palliative approach. doesn't really mean that they're not going to get for example, for Mrs. Lucy, it doesn't mean that she's not going to look at oncology treatment. It just means that we really want to be involved early on, because all of these patients are actually experiencing, first of all, symptoms, and whether it's anxiety about the diagnosis or actual physical symptoms, and they all have life-threatening illnesses. So a lot of you might have seen this and may be familiar with it. So what we're talking about here is that we want to be able to initiate palliative care approach early on, soon after the diagnosis of any life-threatening illness. So we have had actually studies that now prove that when we initiate a palliative care approach early, people not only have better quality of life, decreased emotional symptoms, but they actually live longer. This is actually proven in both the oncology, the cancer population, as well as patients who don't have cancer. So our job right now is to be able to help identify these patients early, help explain to people what this palliative care approach really means, support them through while they are still pursuing the treatments that are directed to the diseases. And then kind of as the disease progresses, we know that our role is going to increase as palliative care providers. And then towards the end of life, obviously, there's a good chance that we'll be taking fully over for their care. What we really want to do too is to bust the myth that most people in our healthcare colleagues, as well as the general public, is still thinking that when we talk about palliative care, we are only talking about end-of-life care, because we have so much more to offer. So when we are thinking about initiating a palliative care approach, a lot of people are saying, well, you know, we want to do it early, but wouldn't that be a time when it's kind of like too early? Like, how do we decide? So I put out here the gold standard framework, which is one of the really helpful references. Some of you might be familiar with like a SPIC tool or some other similar documentation that will help us look at a patient and decide, you know what, is this time where we really should start talking about a palliative care approach? So the gold standard framework starts with the surprise questions. So it basically asks people if you would be surprised if the patient dies in the next, usually the timeline frame is 6 months to a year for most programs. And this doesn't mean that the patient is going to die in the next 6 months or a year. It just gives you that mental cutoff to decide that, you know what, maybe this is something that I need to support the patient with and help prepare the patient and family better for the journey. So I really like using the surprise question, and some of you might know that I'm actually an emergency physician as well. And in my emerge department, I actually sometimes use the surprise question too. But this time I actually changed the time frame to probably hours to a day or two, because again, to me, if someone is encountering a life-threatening illness and I'm not doing my job to help prepare the patient or the family, then it will be really traumatic for the patient and the family. And yet, you know, obviously in the emergency department, I'm not going to kind of start initiating a palliative approach or talking about palliative care approach when patients have, you know, life expectancy of months to years. So this is a question that, again, hopefully some of you will be already using and some of you will find helpful. This step 2 here in the gold standard framework talks about some general indicators. Again, some of this might be common sense, and some of you who may kind of have been journeying with patients for a while will probably pick up on a lot of this too. Like if someone has a lot of different medical problems, comorbidities, if someone has an acute change in their status, like, you know, an elderly patient who had a fall, or someone who's had advanced diseases, those are really kind of quite obvious in terms of kind of, again, triggering you to be, what I usually say, a bit more worried about the patient. Other things that are here are pretty kind of specific. So sometimes we'll use a blood test called the albumin, which is like the amount of protein in the body. And that will actually sometimes also give us an indicator of where things are, or specific numbers like, you know, the weight and how it's changed over time. In the step 3 of this gold standard framework, actually a list, which is like the page 2 that is not on the screen right here. It's basically a list of specific diseases and what you can use to look at how serious the situation might be and whether initiating a palliative care approach will be appropriate. So each disease a lot of times will have their own prognosticating tool, and you can usually find those online as well. So part of step 2 of the gold standard framework also alludes to some measurements of functional status. So I think a lot of you probably have heard of are already using the Palliative Performance Scale, which is shown on the screen left. So this looks at the patient's functional status and provides all our providers with a common language of how the patient is doing functionally. The PPS has been really proven to be a good prognosticating factor for people with advanced cancer, but not necessarily in terms of non-oncological patients or slightly earlier or people who are going through treatment. Sometimes it's a little bit harder to look at and predict what's going to happen to the patients. At this point, though, what we really do know, though, is when we see someone who's having a change in PPS and really not recovering, that again is something that's going to help make us quite worried and really want to have a good conversation with the patients and really want our team to be involved with the palliative care approach. Some of you might also know that my husband is actually a care of the elderly physician. So I put in the clinical frail scale in honor of him and his team, because I know that, this is again another good scale that looks at the patient's functional status. My colleague who does palliative care and geriatrics really likes the scale because it gives people almost like a visual image of where the patient is in terms of the functional status, and that gives them a mental idea of, again, seeing what might be happening down the road. This next slide is one of my favorite in terms of really trying to help us understand the trajectory of the patient's illness experience or the functional status. So historically, because palliative care started a lot in the cancer world, we've been seeing this red line. So we kind of see people who are doing not too bad, and then, as the cancer kind of really progress, they have that dip. And that dip is quite predictable in terms of what's going to happen to our patients. And when we see that the cancer patient, especially the cancer patient who's got metastatic cancer, who's not getting treatment, starts to kind of dip down to a PPS of 70, which means they start not being able to kind of mobilize well, or especially down to 30 when they become bedridden. That's when we really know that, the time is really coming close to the end of life. So that's historically what happened to palliative care, and we were able to kind of pretty well kind of give people a sense of, what, we really want to support you. This is kind of approaching end of life. Now, what's happening though is over time, what we've realized is there's been a big gap in the non-cancer patients that we really still want to take care of, because they have a lot of symptom burden, and they obviously are going through a similar journey of kind of declining functional status and really needing a good approach that will focus on the quality of life, in addition to treating the disease. So what we've started doing is taking care of a lot of people who have more of the organ failure kind of diseases. So that will be more like heart failure or COPD. But these people are what's shown in the blue line. So what we're seeing is these people will have what we call an exacerbation, like a sudden attack or a worsening of the CHF or the COPD. They might be hospitalized or they might get medication, and then they will bounce back. And then they are kind of almost back to where they were. But actually, if you look at the trajectory, they're never quite the same. So it's this up and down, though, that makes things a lot harder for these patients, because, a lot of the times, especially in the medical world, we're so focused on trying to treat these patients from this point where they have the dip, and not being able, and getting them back to where they were almost before. and not really realizing that this decline is happening. And nobody would actually approach a patient and say, hey, you know what, this is actually an incurable disease that eventually is going to make you quite debilitated and eventually cause end of life. So this is becoming a lot more challenging, but a lot of times I find even drawing that graph out to patients and explaining, you know what, like we are seeing this decline. We know that a lot of the patients actually describe themselves as almost like, you know, the cat with 9 lives. So they kind of have the 8 lives now, and now we really need to look at what's important to them and help them kind of make sure that the palliative care approach is delivered in addition to the disease modifying approach or the curative care that you saw in the last graph. So that's basically where things becomes a lot more up and down. And then we also add the complicating part of the frailty and the dementia trajectory. So as the Canadian population is aging, we are seeing a lot more elderly patients where, you know, the baseline function and health is actually not as robust as they want to be. And then they are seeing a lot of these ups and downs as well. And again, you know, not really being able to tell, well, when this up and down is going to eventually lead to the end of life, but then knowing as you're declining in function that, you know, this is obviously unspokenly in everybody's mind. So having that kind of in your mind and trying to kind of picture where patients might be sometimes is helpful. Other times, what I've done is actually starting to realize that at this point, palliative care has become so much more dealing with this uncertainty that we are all seeing with the chronic disease and the frailty than it is about the actual death and dying. So obviously, I still help people kind of prepare for end of life when I see that they have a life-threatening illness. But what I start off with, especially when I'm doing an early initiation of palliative care approach, is really outline to the patient that I know that the journey ahead is going to be very uncertain. There's going to be a lot of ups and downs, and we really don't know for sure what to expect. But my job is really to help them through this. So I really like this quote by Daniel Brzezinski. He's a public speaker from Michigan. And he basically said, uncertainty is certain, which I think is what we're seeing now in healthcare and in palliative care. But fear and worry are optional, and it's a choice. And it is our choice to help the patient's journey through this and help alleviate some of their fear and worry. So next, I'm going to move on to talk a little bit more about assessment and plan. I think this next slide is also familiar to probably quite a few of you. This is our Edmonton Symptom Assessment Scale or system. The ESAT score is a tool that we use to ask patients if they're able, or if they're not able to, maybe the caregiver, to actually score the list of symptoms that the patient may or may not have from 0 to 10. So 0 being no symptom at all, and 10 being the worst symptom possible. And basically what we want to do is to have a visual of what's bothering the patient physically or emotionally here. So there's pain, there's tiredness, there's drowsiness, there's nausea, there's shortness of breath, and then there's one line for other problems that they may be experiencing. It is a bit of a subjective measurement, but again, a lot of what we know about symptoms is what we see and what we think the patient is experiencing is not as important as what they are really truly feeling. So this will kind of help measure that. The good thing about this scale is that it provides a list that the patient may or may not remember to tell us. So for example, someone who's been in pain for years with a bad arthritis might have a pain of 8 out of 10, but because they've been living with it forever, they probably won't actually think to mention it, other than maybe, if they actually have a new symptom, they might be more inclined to mention that, even though it's a milder symptom. And, our job is to address any symptom that we can. And if we actually address the pain of this patient who don't actually think of it because he's had it for years, but we can actually manage the pain better and have him function better, that will be really a great thing, right? So that's sort of what the ESATs is good for. Another thing that's good with the ESATs is it gives us a chance to actually track things over time. So it gives us, a flag when patients had no symptom or very little symptom in one domain before and now has more. Or the flip side is it also gives us a sense of how the patient may be responding to our interventions. When we think about treating these symptoms then, like the first thing I think of usually is, what's causing the symptom? Is this anything that I can fix or that the patient want me to fix? So for example, if it's a cancer that's causing pain, there is a lot of role in cancer treatment if that's going to help the patient without causing too much side effect and without causing too much, demand on the time and is consistent with the goals. Other times, what we're really looking at is pure symptom management. One of the things I really learned one time from my a LEAP course I was facilitating was that we were talking about pain management, and one of my PSW colleagues was actually kind of giving her suggestion about, the first thing she would do is to reposition the patient and put a warm blanket on her. And that was really my aha moment to think, you know what, this actually is amazing because like I was about to talk about what opioid we were going to use and stuff, but honestly, the warm blanket is probably going to give the patient the most immediate relief and a better relief than any medication that I can offer. So think about your non-pharmacological treatment for sure for any symptom, and really think about also looking at your team for expertise as well, or any other colleagues. And then there are pharmacological or medications that we usually would use for all the symptoms as well. Now, remember I also talked about when we were assessing patient, we also want to be assessing the patient and family, and we are really wanting to be touching on all the domains. So this diagram is from the Canadian Hospice Palliative Care Association, talking about really the domains we really want to be looking at, from physical, psychological, social, spiritual, practical domains, to think about disease management, thinking about anticipating the management of loss and grief, and end of life care. So all of these will kind of be our comprehensive assessment for the patient, and then as we see a need, then we work with our team and the patient to really look for a plan to manage them. To me, some of these actually look pretty daunting because, I mean, again, I'm a very medically trained person, and, I think being part of palliative care and learning from all my colleagues over the years have really expanded my horizon to think about the other domains. The other thing that's really good though is it's really helped me network with everybody who have expertise in treating the different domains. So this really resonated with me when I saw the palliative care health service delivery framework by the Ontario Palliative Care Network, to really look at, again, we're not alone in this. All of us are working together to really provide for the patient and the family in palliative care. So we define the team as the core team, and it doesn't have to be like, in the interprofessional team that some of us really automatically think of when we talk about teams. It could be really just the primary care provider, whether it's a physician or nurse practitioner, as the really core team, and then really leaning on extended services that you may have in your region. It could be, again, I remember when I was in Ellie Lake, we were pulling together a palliative care team, and a lot of our expertise actually with grief and was from our volunteer organization, as well as a funeral home director. Like they were actually taking on a lot of that, work surrounding the actual period of death to help with what we may not think was available in our region. So the extended service with the core team, and then there is a palliative care specialist, usually, again, whether it's right in your region or in the surrounding area that you could tap onto. And the most important part in here is to be able to coordinate the services here. So by working together, we can really help the patient to be able to be prepared for the worst and hope for the best. So speaking of hoping for the best, I would actually like to share a story with you. This is a story of one of our patients. I've modified his name to John. John is a 61-year-old guy who was admitted to a hospital back in a couple of years ago now, almost a couple of years ago, with end-stage heart failure, and he was getting more and more weak. So he was in the hospital for 3 months altogether, and actually continued to decline. He needed more oxygen. He lost a lot of weight, and he was eventually bedridden. By the end of March, it was decided that he would definitely be appropriate for a hospice admission for end-of-life care. They had done a echocardiogram and ultrasound of the heart at that point, and they were saying that he had an ejection fraction of 11%. So really, the heart's pumping very little blood because it's so weak to the body. Over the next few months in the hospice, though, his heart failure actually stabilized. So we recognized that he was no longer actively dying, and we ended up trying to figure out where we were going. So we actually started talking about rehabilitation. So we actually had physiotherapy going into our hospice and started working on John. This proved to be pretty challenging because John is a very tall man, and now he has very little muscle that can carry him around. So every time we made a little bit of progress, we inevitably have a bit of setback as well, because then it will be like a joint or muscle that will be aggravated, and then John will be kind of not able to do what he wanted to do again. It was also emotionally really tough on John because we were trying to set some goals and help him move forward, but the pressure soon became too much, because he himself had a really strong desire to push himself. Over time, though, with the sheer determination of John and the support from our team, we actually managed to make progress. So he started transferring to and from his wheelchair, was able to wheel himself to a porch to look outside. Then he started taking steps. And the last time I saw him in December, he was actually making it up and down some steps. And this was enough eventually to get John home. So he was actually discharged from our hospice last month to go home. And at that point, though, miraculously, when we were looking at his echocardiogram, his ejection fraction was actually 50% or more than 50% and almost normal. So this story kind of really resonates with the bow-tie model that Dr. Pippa Hawley has proposed. So I'm going to kind of share that with you. There is the model actually shows the relationship between the treatment arm or the disease management and palliative care, as well as outlined here. So we have a traditional therapies for disease management. But then when we think about the palliative care arm, of course, there's a lot of pain and symptom management as we're doing disease management. But towards the end, when the disease actually stabilizes, or kind of the disease management side becomes not applicable, we're actually now seeing almost like two arms. We have a traditional end-of-life care, where we take care of patients in our usual way, whether it's home or palliative care unit or hospice, and we look at grief and bereavement. But we now also have this patient population that is going through survivorship. And these patients are left with significant deconditioning that requires rehabilitation, as well as a lot of mental health impact. They need support. And what better people to support these patients than our palliative care team, who already knows very well how to support people who's been through a life-threatening illness. So this kind of brings me to the next section of the talk, because now that we know what we want to do with our palliative care approach, being able to have a good patient-centered decision-making approach really complements what we do. So I'll start off with the picture that I borrowed from HPCO, but this picture actually represents a lot of what we see. Like I was telling you, I work in the emergency department, and we definitely see a lot of people in this situation coming in with life-threatening illnesses. And the case that really came to mind that started me going on all this pursuit of what really means to be having a good conversation is a 90-year-old frail elderly who was transferred from the nursing home with moderate dementia. She was already wheelchair bound, and she had a really nasty urinary tract infection, probably septic from it. She was dehydrated, her blood pressure was low, and she was looking like this, and probably worse. I at that point was actually I had just arrived in Sudbury, and I was actually also working as a hospitalist. So I was receiving a phone call from the emerge physician who was really frustrated and said, you know what, the son is really being totally unreasonable. Like, he wants everything done for this patient, and this poor lady is just like there moaning, and she's probably going to die. And, but at this point, the son has actually reneged the do not resuscitate order, and he really wants everything done, even though it might seem unreasonable to the emerge physician. So I walked into this room, and I saw, obviously, this patient who was semi-comatose and moaning, but I saw a son who was really, really struggling and distraught. What he was able to tell me is that, they were at the nursing home, and mom got really sick, and the nursing home physician basically has said, we really should just keep her here and let her go. But he was really, really not wanting people to give up on his mom and wanted her to be given a chance. So he insisted on a transfer to the emergency department, and then he was experiencing the same trauma where he felt like the healthcare team just wanted to give up on mom because, they were not going to treat mom. It was this experience, together with, my role in palliative care and emergency medicine, that really cultivated my interest in the approach to person-centered decision-making and how to have better conversations with patients. So I'm kind of going to go through some of the material from Hospice Palliative Care Ontario with you. And really, when we first start talking about person-centered decision-making, we really need to understand what informed consent as well. So informed consent is the permission for healthcare providers to proceed with any course of treatment or care for the patient. This may include anything from even having a visit from the team, receiving personal support care, getting physio, getting like nutritional supports, anything that really has to do with what we are trying to implement as care plan with the patient. So it doesn't really necessarily mean just a consent that, an MD might get from the patient for surgery or things like that. Now, with the Healthcare Consent Act, what it dictates is that unless it's an emergency situation and consent cannot be obtained, the healthcare provider who is providing the care must obtain consent, which is supposed to be an informed consent as well, from the person or the substitute decision maker, the SDM, at the time just prior to initiating the treatment. So the consent needs to be really just before the treatment is initiated. It shouldn't be something that was done like a year ago, because we really can't have an informed consent then. And we really need to have consent before treatment. And we also need to actually be able to assess the capacity of the patient and or the SEM before the consent is obtained. So we know that when the patient is incapable, we turn to the SEM for consent. So this is the base framework, legal framework that we're working with. And this is what person-centered decision-making looks like in an ideal world. So like we were saying, when there's a medical event or any event that requires a change in the care plan of a patient, we want to obtain consent before treatment is initiated. Prior to the consent, though, what we want to do is to have a goals of care discussion. So this is a discussion where we want to establish the goals for treatment, and make sure that the patient or the SCM understand what's going on, and really try and align things, the clinical situation with the goals to be able to get the consent. Now, in the real world, a lot of the goals of care discussion can be very stressful and difficult, especially when it's in an acute situation. And there's a lot of information that needs to be shared and processed in a very time-sensitive manner. So that's why we really want to promote advanced care planning, where conversations about the patient's values, wishes, and beliefs can be shared ahead of time without that stress of the event and without having to make decisions right away. So this advanced care planning is what we're trying to really promote that will greatly facilitate conversation that might happen down the road. So I've been throwing some of the terms at you with advanced care planning, goals of care, and consent. We've already explained what consent is, but I just want to kind of again reiterate what each of these terms means, because there's really been a lot of confusion, misunderstanding about each of these terms. A lot of people actually don't know the difference between advanced care planning and goals of care. And goals of care, a lot of times, even at the hospital right now, when we talk about it, people are really thinking about just decisions about cold status and ventilation, and really not thinking about the goals of care discussion that happen before every consent. So HPCO has done a lot of work to clean it up, and I'll share with you their definitions and explanations. So advanced care planning really refers to the conversation that we use to confirm a person's substitute decision maker, and it focuses on values and what's important to the person, and it's not a consent for future care as we talked about. Goals of care discussion is discussion that is happening in the context of a current illness about a person's values and goals that lead up to a treatment or care decision. And like we were saying, it aims to align the available treatment options with the person's goals so that we can actually obtain that consent with a conversation between the healthcare provider and the patient SDM to get the permission to initiate treatment or personal care. So this slide kind of talk a bit about the patient's journey. So from a patient's perspective, as they journey through their illness, there are many different settings that they may encounter healthcare and providers. So like we were saying, at each point when the decision, whether there's a D on this line, needs to be made, we have a goals of care discussion. And what we're really trying to encourage is that in any of these other times in between, whether you're at home with a client, at the clinic, in acute care, or down the road when you're in long-term care, or even in between decisions when you're in a hospital or critical care again, or near the end of life, all those times that we have conversations when no decisions need to be made will be good opportunities to have advanced care planning conversations. So what we're trying to invite you to do is really think of your role in your practice and how you can engage your patients in this. Because by all of us taking a role in this, we will be able to avoid the most difficult time to start this conversation, which is with a provider who is a stranger to the patient and the family at the moment of the patient being in extremis. So I'm going to cover a little bit more of the advanced care planning and goals of care in detail. So let's start with the advanced care planning. Like we were talking about, there are really two main components. We want to confirm the SDM, and we want to confirm the patient's values, goals, and preference for healthcare. Now, the important part too, though, is to make sure that the SDM actually understand the values and goals and preferences. So that's what we want to be able to do in advanced care planning. Beyond that, though, it's often helpful for family and friends and for the whole healthcare team to be also aware of the patient's values, goals, and preference so that we can support the patient and the SCM when they have to make decisions in a stressful time. Legally, what we do is we actually are supposed to honor the patient's last known wishes, and this actually can be verbal or written. So anything that's the most recent actually trumps anything that's even written. On the other hand, that's why we actually recommend that every time you get something important information about the patient's values and goals and part of the advanced care planning, you want to probably document it so that the rest of the team and the patient have a reference to it and the SCM. Now, when we talk about the SCM, I think some of you might be aware of the hierarchy that's present through the Healthcare Consent Act. This one that's shown is our Ontario's SCM hierarchy. Most provinces and countries will have a similar hierarchy. So in other words, even if a patient has not identified an SCM for themselves, the Healthcare Consent Act actually assigns a SEM for the patient. So we basically go from the top of the hierarchy to the bottom and find out who is actually the highest level for the SEM, and then approach that person for consent if the patient is not able to speak for themselves. On the top here, you have the legally appointed SEMs, so that can be court appointed, or that can be appointed by the consenting capacity board, or it could be a power of attorney document that the patient has signed. Now remember that the power of attorney document doesn't actually need to be signed by a lawyer. A patient can actually download the document, sign it, and have it witnessed, and that's a perfectly legal document. If a patient doesn't have a legally appointed SEM though, then we go down the hierarchy of the automatic family members SEM. So what we have here, the top is usually the partner or the spouse, and legally that has to be basically anyone that the patient identifies as a significant partner, whether it's in a romantic relationship or not, doesn't matter, but it's someone that the patient designates as a partner for more than a year. The next line is actually the parents or children. So we always kind of present a situation where a patient might have 2 elderly parents and 5 children. And knowing that really by law, all 7 of these individuals need to be consulted and agree and have a consensus in order for you to proceed if there's no legally appointed SEM. So that gets a bit more tricky, right? And then we kind of keep going down, and if we don't have any family members that we can approach, then we go to the public guardian and trustee. So again, to reiterate, what an advanced care planning does is it try and either confirm the automatic SCM down this hierarchy with the patient, or if that's not the person that the patient feels will be the best person to speak for themselves, then you help the patient prepare a power of attorney paper for personal care. A couple of fine points too, the SDM has to be 16 years or older, and when we speak with them, they have to be willing and available, and of course be capable of giving consent. So the next thing I wanted to touch on is something that we kind of already alluded a little bit to, is the fact that advanced care planning is really not a consent for future treatment. So historically, a lot of people have confused advanced care planning with advanced care directives, which actually has no legal standing in Ontario. But more importantly though, the practice of using advanced care directive is actually not particularly helpful and something that we want to move away from. Because imagine really, we can't predict what treatment a patient may need in the future, because we don't really know what the clinical situation will be at the time that they need that particular treatment. So having an informed wish for or against a hypothetical treatment will totally be not helpful for the patient or the SCM or the team. So one example that we have put here is the level of care form that actually I was an enthusiastic proponent of it about 10 years ago, thinking that, you know what, it's nice to have something written down. Now I know that this is really not reasonable or something that is actually a good practice. So for those of you who may not be familiar with it, this is a form that we used to have in a lot of the long-term care facility that we go over with the patient or the resident and the family on a mission, and pretty much annually about, you know, what level of care they would want. So if you were to get sicker, would you want to have palliation? Would you want to have transfer to the hospital? Would you want to have resuscitation or something like that? Now reflecting back on it, I know that it won't work, because I'm kind of thinking, well, if I'm a resident getting into a long-term care facility and someone asks me if I want to be transferred to the hospital and sign a form about it, I'll be like, well, what do you mean? Like, are you talking about if I'm dying and do I want people to poke at me and try to keep me alive and do all sorts of tests to me versus staying at home? Are you talking about if I was to break my wrist and have a fall, whether I want to go to the hospital and have a cast? Because obviously my answer will be different. So instead of doing this now with advanced care planning, what we really are doing is trying to do everything we can to help prepare the SCM for making future healthcare decisions. So again, just to kind of go through this point again, there are certain times when it's foreseeable in the near future. For example, someone going into a stomach or surgery to remove their stomach, to ask if they would want a feeding tube if things don't go well. That probably makes sense to help them start planning, because this is more relevant. But really blanketing and interventions and asking them to kind of almost like pick from a menu and see if they would want certain interventions is really the practice that we want to move away from. One of the analogies that I borrowed from Dr. Incardona and Dr. Steinberg when they were giving the person-centered decision-making presentations has to do with food. And of course, like, I mean, not trying to be stereotypical, but me being a Chinese have made me really want to think about food a lot of times. And I know it's a little bit early to think about lunch, but hypothetically, I could easily be asking my family to order, Chinese takeout for me for lunch right now. And of course, because I'm presenting, this might be a problem, because I could easily have, like, for example, ask them to order sweet and sour chicken for me. But if I'm presenting and the dish is not available, would they be able to know what I want then? Because they wouldn't be interrupting me right now to ask me, right? So, I mean, let's pretend that there is, sweet and sour pork or kung pao chicken, but no sweet and sour chicken. So if they were saying, well, Christine really wants sweet and sour chicken, but we don't know anything else, that really won't help them. Yet, if they were able to know that, what, sweet and sour is not something that I'm dead set on, I like it, but it's okay if I don't have it, but I really prefer chicken, and I can have spicy food, then they will definitely know how to pick kung pao chicken and not sweet and sour pork. So the analogy here is that if you know how people choose rather than the choice itself, this will be able to help you and the SCM translate that preference and that value system into all future decisions, instead of trying to really pin down decisions right now when you don't even have the context or the options available in advanced care planning. So hopefully that clears things up a little bit, and that definitely is a big practice changing point for me, and that's why I figure I'll probably want to share this with you. So when we look at the advanced care planning steps that is presented by HPCO, here's where they are. So they talk about assessing capacity. They talk about exploring the patient's illness understanding first, because a lot of people don't actually understand the trajectory of the medical conditions, and really taking time so that the person can tell you what they know is really important. And then you want to find out what information they might need. I find when I was working in the cancer center in palliative care, a lot of times what has happened was we would have a conversation with the patient to try and think about what their care might be like, and they will have a lot of unanswered questions. And those questions were actually not questions that I, even as a physician, can do. It would be the oncologist who can answer that. So my job became really helping the patient explore what information they need so that they can bring it to the oncologist. Similarly, a lot of times when they were given information, my job was then to look at the note of the physician or the oncologist, and then sit down with the patient and help them understand what the oncologist really talks about. So again, I think we are all from different sectors in this conference, and a lot of us have different backgrounds, but really knowing where your scope is, but also knowing that, we don't have to have all the answers. Some of us are a lot better at really understanding where the patient is and understanding their needs. And this is really where we may be able to make a lot of difference to be able to help the patient navigate through the system. The next step in ACP is really talking about the values of the patient. And I can talk a little bit more about it on the next slide. And then the last step is to plan, so that if the SCM is not present in the advanced care planning process, we want to make sure that we have some way of following up, whether it's the patient themselves talking to the SCM and making sure that that's being done, or bringing the SCM back, which will be ideal as well. So I promised you that I was going to talk a little bit more about values. So this is actually the advanced care planning documentation tool that you can find on the Speak Up Ontario website, which is where all the HPCO resources are. So this tool consists of the 6 questions that Dr. Maya's team had come up with. So the first 2 questions, I know it's probably hard to see, has to do with the illness understanding and information need that we talked about already. And then the next question is actually a guide to think about values and quality of life. So really asking patients to kind of identify what constitutes quality of life and what's important to them. Question number 4 is actually worries and fears. So really, again, exploring what worries and fears they might have, and then, you know, having the team being able to use this to help address things as things pop up. Question number 5 is always a weird question. It's called the trade-off question. So that speaks to basically asking patients what they're willing to trade off. For example, if you can live longer versus, you know, giving up some of the like time with family, all the things that are important to them. And then the last question is really asking about, you know, when you think about end of life, what is important to you? So that basically concludes the little bit of advanced care planning update that I want to give you. Now that you've learned more about it, though, I do hope that you will see a role for yourself. The more we normalize and all encourage the patients to proceed with the advanced care planning, the more likely that we're going to be able to help these patients towards person-centered decision-making. So now I'm going to quickly cover goals of care. As you can see, HPCO has actually outlined very similar steps to advanced care planning for goals of care discussions as well. So again, it really is the same communication skills that we're employing, but just applying in a slightly different context. So I'm going through each of the steps that we talked about. So in preparation, what we want to do is reflect on the expertise that we have and, you know, our knowledge and how this might apply to the patient's clinical situation. We want to be very much prepared for any emotions that might arise, because we know that a lot of these conversations are very hard for patients and families. And for some of us, you know, occasionally, depending on the clinical situation, it might even be quite hard on ourselves. So being aware of it and be ready to deal with that will be really important. The last one is actually a really interesting one, because it is basically leaving your agenda at the door. Because a lot of times when we actually look at what we have planned for the patient, a lot of times we'll go into the room thinking that this is what we're going to talk about. But until we actually know the patient's perspective, we really can't make a plan. So really kind of, again, stepping back and know that we need to put all that aside until we've had the conversation is really important. The next step in the goals of care discussion is illness understanding. So here's some of the suggestions from HPCO and from, I think some of it is also from our team, of what phrases you might find helpful. The thing to remember is when we think about illness understanding, it's really more about exploring what the patient knows. Even if time is short, spending that few minutes to step back and ask them where things are will be really important. I have a very recent example of walking into a patient room when I was covering inpatients at HSN. This was a palliative patient that I've started establishing a rapport with, covering for the weekend. And actually the day before, we were actually just all celebrating how he seems to have stabilized, and the family was feeling him a little bit more, and really kind of looking at maybe being a little bit more hopeful that he might have a couple more weeks to live and be able to spend some time. The next day I walked in, I walked into the nursing station first, and he apparently has taken a nosedive. He was unconscious or semi-conscious, having trouble breathing. We think he might have aspirated, and just was really looking quite poor. So at that point, the nurse was actually pulling me aside and say, I'm quite worried because the spokesperson actually was asking me about resuscitation. And I was like, oh, okay. I guess this must be a shock to him, but we had really talked about palliative care approach and end-of-life care prior to that. So I walked in that kind of armed with kind of like thinking about how I can again rebroach the subject of really focusing on comfort, because resuscitation at this point is not going to be helpful to this patient. But I decided to kind of do this approach and sit down and really check in with the patient and the family first and say, how is it going? Like, where are we? And the spokesperson actually say, oh, you know what? In the last hour or so, we've had a lot of time to spend to chat together. And you know what? We come to terms with it and we know that the end is coming. So it was like, wow, you know, I was so glad that I've decided to actually kind of do what I preach and really explore the illness understanding first, because this conversation obviously took a very different turn than what I would have anticipated. Now, moving to the next step in the process is the information. So basically here we want to get the permission first, make sure we give patients small chunks of information at a time. And then the most important part here is actually understand the concept of the emotional gap. And this is something that over time that I've been taught and actually realize is true, that a lot of times when we think people are in denial and we keep kind of giving the information to the patient, thinking that maybe this will actually sink in better because we just going to, as one of my patients once actually accused me of doing, like putting more nails in on the coffin. But really what is happening is when people have a hard time with processing information, usually it's because of an emotional gap that hasn't been acknowledged and addressed. So when we actually address the emotion, that's when the information will be able to sink in, and the patient can actually, and the family can actually process the information. So remember, information always comes with emotions, and really when you give information, be very prepared and to spend more time to address the emotions. When we talk about values and goals, we have already covered it in the ACP, and hopefully, over time, more and more people will have had ACP done. So we're really focusing on a lot of different aspects of the patient that will actually take us to arrive at the values and goals. And really, one of the best questions I've actually learned is just asking the family or the patient to just tell us about them. Like if we genuinely want to learn about a patient and be open-minded, there's a lot of information that we'll be able to get out of just talking to the patient. So once we've actually understood the values and goals, a lot of times I like to actually kind of conclude with this, with almost like a common goal that we can actually realign the patient, family, and the whole team with. I like to kind of think that we're going to continue to do everything we can, as opposed to some people thinking that when we think about palliative care, we actually stopping active treatment. We're actually being even more active in addressing the patient's values and goals and preserving the quality of life. The other thing that sometimes happens too is in your conversation with the patient, you might actually have specific goals that that has been uncovered. So these might become the focus of the treatment plan to really help the patient attain the goal. I remember once we've actually intubated an actively dying patient who has a terminal illness in our emergency department, because the main goal is to help the favorite grandson be able to make it from Toronto to say his last goodbye. So again, a lot of times really understanding that if we can actually put that as a goal rather than managing the disease, this will be a lot more patient-centered and really add to the care the patient is receiving. One little tip that I have too is when I have goals that seems unrealistic and unattainable, what I've kind of gotten into the habit of doing now is naming these goals as a miracle. Of course, we have all seen medical miracles or miracles otherwise in life. So for me, helping a patient maintain the hope for a miracle is actually not unreasonable, as long as I've labeled that as a miracle. So by doing that, what I'm hoping to do is, first of all, not have them lose that hope in the miracle, but also allow them to be more prepared should the miracle doesn't happen, and also look at other goals that they could also work on at the same time. So the last step in goals of care discussion is the making a plan. So what we really want to do at this point, like we were alluding to, is to put together the information and evidence that we have with the goals of care and make a decision. And that's the essence of a goals of care conversation and how we want to get consent for patient-centered decision making. So one of the things that I've done over time with my team is to actually come up with this, what we call the four quadrants. So what we do now is have a traditional way of thinking about medicine and thinking about treatment along how efficacious they are versus whether they're harmful and have side effects, but also add the second axis of the patient's values and goals. Now, obviously, this is not a language that we want to use with the patient, but it's how my brain kind of works to think of, if everything works for the patient's goals of care and it works medically, then it's a no-brainer. We should just go ahead. The flip side is if something is what we think of tradition as futile, I'm not going to say use that harsh term, but I'm going to really be honest with the patient to say, hey, you know what, this treatment is not going to work for this situation anyways, and it really takes away from your goals and your quality of life. We really should not be doing it, and having that confidence to recommend against it. A lot of times, this is where the resuscitation conversation goes too. And then anything in between where it may be a conflict between the goals of care and the medical efficacy is when I actually kind of use almost like the trade-off question. So this is the goals of care documentation template that is also on the Speak Up Ontario website, and it's very helpful because it basically reminds us what to cover during a goals of care discussion and give us a tool to document it as well. So in terms of basically, again, really trying to think of all of us being a part of it, I think, if the advanced care planning conversation is done really well, then whoever is getting the consent and having the goals of care discussion will have a much easier time. Otherwise, too, there are times when we know that an imminent decision needs to be made. We still can count on our team members and each other to whoever has time and has known the patient well enough to be able to speak up about the patient's values and goals so that the decisions can be made based on that. So I'm going to jump now to kind of give you just a quick wrap up on my patient. So at that point, I was actually able to talk to the son and reassure him that we will not give up on mom. We will focus on what's really important. And we did decide that, giving mom a chance to recover from this with IV antibiotics and IV fluids is reasonable, knowing that any further escalation to ICU will not help mom. And really also knowing that neither the son nor us want mom to be suffering. So like the first thing I did was I actually ran to the our medication room and pulled out a small dose of Dilaudid or hydromorphone and actually injected right into the IV for mom just so that she could actually settle down. And I think that even not having mom looking uncomfortable actually put a lot of ease in both of us. This patient actually ended up having her IV fell out and the son decided not to pursue the IV and more blood work because it was hard on mom, but she actually got better and went back to the nursing home for another couple of months before she succumbed to her next illness. So again, lots of kind of learning that I've done through my career, and I'm really hoping that this is helpful to you. Now, in this last part of the presentation, I wanted to share with you some of the work that's been done. Now, this is the WHO documentation on quality health service and palliative care, and I think all of us are striving for this. It speaks to care being effective, safe, person-centered, timely, equitable, integrated, and efficient. The COVID-19 pandemic has certainly made attaining and realizing these ideals a lot more challenging. Indeed, it's been a very tiring journey for a lot of us, working with constant changes, increasing patient needs, limited resources, including health human resources. And the pandemic has highlighted the needs for even better palliative care. It is in times like this that I think we as a group of palliative care providers, driven by our passion, has really risen to the challenge. And I think I'm thankful that there's so many of us who is not afraid to think outside of the box and be innovative. So in this last section, I really want to share with you some of the success stories of quality care provided by our teams regionally. And this is by no means an exhaustive list because I know that a lot of you are doing amazing work out there. But what I want to do is to highlight some of these examples so that we can all continue to support each other and inspire us in what we do, because what we do obviously matters a lot to everyone around us. So I'll start off with this presentation that Trish LaFantasi has kindly agreed to give us. Trish is our Director of Care at the hospice, Maison Marcel Hospice in Sudbury, and she's also the chair of our Hospice Palliative Care Sudbury local table. I'm going to try and play her presentation for you.
In the greater city of Sudbury, historically various teams serviced this vast region's cancer and chronic disease populations independently. Likelihood of patients falling through the cracks increased, and seamless transition between care sites was lacking. In order to improve equitable access to hospice palliative care and facilitate preferred location of death, a community collaborative model of palliative care was developed. In 2014, 3 agencies took a leadership role and formed a collaborative multidisciplinary specialized palliative care team with no additional financial impact on the healthcare system. This team now serves community residents in their last year of life and has developed creative systems to improve wait times for seamless, timely care to residents by expert clinicians, ensure equitable access to palliative care services for patients with chronic disease at end of life, integrate a palliative approach in other settings by acting as a resource for primary care, educate medical, nursing, social work, and PSW staff and students, equip and educate families to better care for their loved ones dying at home, deinstitutionalize care which normalizes death and dying and enhances grief and bereavement services, thus enhancing caregiver support. This team has continued to work through the pandemic, providing virtual care and ongoing home visits as needed. In this region, dedicated practitioners continue to advocate to improve hospice palliative care services. The hospice expansion and addition of 10 more hospice beds, 6 being alternate care beds, the work toward a central intake for palliative care, virtual care programs and palliative care and grief and bereavement services, and the palliative care paramedicine program. Our region has come a long way and continues to progress.
So I really want to thank Trish for preparing this in a very busy schedule that she has. Trish has mentioned telemedicine, and I wanted to kind of do a bit of a shout out to our PSMC and supportive care team at the Northeast Cancer Centre. We have been using OTN and teleconsultation for out of town and remote patient as a regional center even before COVID hits. We have also been using telephone calls and frequent patient checkups with telephones. So when the pandemic hits, the physicians and the staff were able to leverage on the existing workflow and technology to provide consultation and follow-up with the patient without any disruption of care. And this actually really showed that we know there's a lot of talk about telemedicine taking the center stage in the era of COVID, and definitely the Cancer Center team was way ahead of the curve. Meanwhile, though, Maison Marcel Hospice has also expanded the virtual services. One of the situations that I had the privilege of being part of was actually being able to conduct OTN, which I've done before, but this time actually with the coordination with our home care nurses right on site. There's some patients who are very technologically challenged, so being able to have the home care nurse go in with the technology to allow me to see the patient, but also having that real-time nursing assessment was really, really helpful. There were real-time vital signs. A lot of times the nurse will even do like chest exams, abdominal exams, like let me know what exactly they're seeing, and that was helpful. In addition to also having nurses who have information about medication and what the patients are doing and using for medication, all that kind of expertise right in the home when I was seeing the patient was really a true example of how we can leverage on virtual care and our team. Virtual care certainly also has the advantage going beyond the public health precautions and the efficiency that allows me not to need to go travel distances to homes while being able to see the patient visually. I found that my communication has actually been better sometimes with patients via video conference than actually in person, because they can actually see my face, my lips, my facial expression. They can even turn my volume up because sometimes I tend to mumble, and they can actually hear me better. So over time, I've actually adapted some of that virtual care techniques too. I remember one time when one of our nurses were doing the initial assessment, and the patient was telling a sad story. So I literally went like this, and the patient actually saw me and actually laughed. And actually, that was almost like an instant bond that we had, because this is how they knew that I truly was listening and connecting. Other things I was doing sometimes will be like, asking patient literally to show me the elbow like this, or, really have the camera point to the part that is bothering them, so that I can actually assess that body part. So like not traditionally just seeing the face, but using the technology to our advantage. Speaking of virtual care too, under the leadership of the manager at Maison McCulloch Hospice, Norm Blanchard, Maison McCulloch Hospice has been able to continue to offer grief and support services along the grief and bereavement continuum of care, and this is all done virtually. So although 2 of the grief services are still suspended, namely the memorial service and the 8-week grief recovery program, the total number of interventions has actually increased by 27% from pre-pandemic period. And I know we're going to hear a lot more about grief in this workshop, which I'm thankful for, but definitely there's a much higher need now. And training is now being done to offer the grief recovery program online as well through Norm's team. Norm has actually provided us with this graph that shows an overall increase in the number of interventions thanks to the virtual platform. The overall number of grief service participants has actually increased by 65% to date, with some programs still being under development, as we were talking about. There's an exponential growth from pre-pandemic to pandemic period of 350% for one-on-one coaching via the Zoom platform. In December of 2020, the Maison McCulloch Hospice was able to apply for a grant that helps fund virtual technology. So they are able to continue to offer this service. The grief discussion group that happens bi-monthly is added to the roster of the virtual grief support, and there is a total increase of 69% compared to pre-pandemic level as well. So like we can see here, we have been able to adapt to the needs of the community and adapt to the virtual delivery to be able to service more patients. And post-pandemic, we're really looking at continuing the virtual care in addition to in-person care that will allow the hospice or the Norm service to reach out to more people in our community. Trish has also alluded to our new beds. So here's another clip from Barb that will introduce them.
Hello, my name is Barbara Ballantyne, and I'm a clinical nurse specialist working out of Sudbury with Dr. Punn. Together, we provide clinical care to folks in the hospice and their homes. We also work as the clinical co-leads for LIN 13 in palliative care. I have the pleasure of spending a couple of minutes with you now to tell you a little bit about a success story, a project for which we have secured some demonstration funding. This project is housed in our hospice. The Maison McCulloch Hospice, as you may or may not know, underwent a large expansion from 10 to 20 beds and opened to its full capacity approximately 5 months ago. We now have 14 traditional end-of-life beds and 6 palliative care demonstration beds where we are moving up the trajectory of care from end-of-life care to palliative care delivery. In collaboration with many community stakeholders, we have developed 4 bed types for people in our community. An overview of these bed types is highlighted in this slide. Some high-level information about these beds include: these are adult beds for people whose life expectancy is more than 3 months but less than 1 year. Beds are intended to help people as well as their caregivers. People are admitted from the community. Situations are stabilized so people can return home, and admissions are no more than a month in length. The first bed type is called the complex unstable bed, where we bring in someone who has a new medical problem with palliative goals, such as an acute delirium or pain crisis. The second bed type is to support caregivers, where we bring in the loved one and provide the caregiver with upskilling so that we can successfully help them manage to transition home and care for their loved one. The third is the caregiver relief bed, where we offer caregivers a place to have their loved one taken care of while they attend to their own personal crisis, such as maybe the need for a surgery. And finally, the transitional care bed is someone who is medically managed very well, but there are issues ongoing in the home, such that staying home is not feasible and long-term care is not suitable for this person. We think of folks who may have an incurable primary brain tumor or metastatic involvement of their brain and behaviors that are difficult for loved ones to manage at home. Some of the overarching goals of our demonstration beds are to avoid unwanted hospital admissions, empower caregivers, and facilitate dying in place of choice. While we are early on in this project, we have already had some success towards our goals, and we have certainly moved the needle from end-of-life care to palliative care management in a hospice setting. Thank you.
Thank you, Barb. So moving out of the hospice I would also like to touch on some of the other COVID response efforts that we've had. Early on during our COVID-19 response, I've had the privilege of being part of an amazing community effort that was initiated by Dr. Joanne Clark and the Northeast Specialized Geriatrics team in collaboration with the community paramedics to look after elderly patients in the community diagnosed with COVID-19. We're able to connect with them to assist in incorporating value-based goals of care discussions on the assessment template, as well as pulling together a core interprofessional team on short notice that will be able to attend to the patients who prefer to pursue palliative care at home. Soon, the response also included home and community support services, as well as collaboration with HSN in the emergency department and the inpatient team. It was really great to see the whole team and everybody pulling together to really attend to the vulnerable population. At the regional level, we're also able to collaborate with the Northwest Palliative Care Network and Ontario Health and hold a region-wide webinar to educate patients and families in the retirement home setting on advanced care planning. Speaking of more advanced care planning and goals of care, our goals of interprofessional champions have worked on spreading HPCO resources across the region. We have developed a simulation program for advanced care planning and goals of care over the past few years in order to help healthcare providers and trainees to hone their cognitive and communication skills in advanced care planning and goals of care discussions. We have adopted our format now and cases to suit the audience, and also have been able to continue to offer these training virtually throughout the pandemic. Last year, we have presented our work at the healthcare with the healthcare learners to the HPCO Dragon's Den, and we were honored to have won both the Judges and the People's Award there. In Sault Ste. Marie, Dr. Booth's team has also successfully implemented a workflow for advanced care planning and goals of care with documentation on the hospital EMR Meditech expense. They were able to train advanced care planning champions who are social workers and nurses in the cancer center as well as the renal program, who are now documenting the advanced care planning conversations in expense. These are now easily accessible by all providers, and all doctors can see in their goals of care widget on the patient summary in the main page. And information about the SDM is also flowing in the contact as well as the goals of care widget. So those are like little boxes within the screen and are very user-friendly and accessible by all healthcare providers. So there's a lot of positive feedback on the ease of use for both the inputting providers and the providers who are seeing the information. And throughout the implementation process, the team has had many learning opportunities to share and improve things regarding education, training for providers, and the implementations process for the departments. So thanks to Dr. Booth's team, our whole region can now take advantage of this work as we all move towards Meditech expense in our hospital system. In Timmins, we also have a success story with the Timmins Integrated Palliative Care team. It started with an open dialogue with the 72 primary care providers who are MDs and nurse practitioners in Timmins, with a survey that's designed to identify gaps and barriers to care and addressing them through education and collaboration. They have clarified the definition of palliative care approach, addressed early identification, defined the primary care provider's role, and facilitate the primary care provider's access to the Timmins Integrated Palliative Care Service via a no wrong door approach. So they can do it via home care, home and community care support services Northeast, or through Timmins and area family health teams, palliative care and navigator. The core team with the members from HCCSS NE, and the Timmins Family Health team continue to work with the integrated team members across organizations and discipline with enhanced communication to improve patient, family, caregiver, and provider experience via a very cost-effective, integrated, and collaborative model of care. Last but not least, locally, our City of Lakes Family Health team has been the regional leader in promoting primary care palliative care as well. They have established a primary care palliative care pathway within the family health team that includes EMR reminders for early identification, palliative care needs assessment, and advanced care planning. Natalie Chisholm, who is a nurse practitioner and champion in this work, has also worked with a lot of the physicians with a shared care model to offer patients palliative care services in their home when their preferred place of death is home. So the physician will continue to be the primary provider, but when they need support, they will actually refer to Natalie, and they will provide a blend of home visits, regular phone calls, check-in during the pandemic. The City of Lakes Family Health team has also leveraged on technology and been using some of the tools for the ESAS we talked about and the PPS via a digital format if the family and caregivers are comfortable with it. So I want to end my workshop with this video from the City of Lakes Family Health team. I think that really speaks to the great work that they've done and resonate with a lot of us.
Our palliative care pathway was created to improve our patients' last stages of life. We will continue to make a difference in primary care by sharing our tool. We will facilitate learning sessions in advanced care planning and early palliative care approach. We want to plant the seed of palliative care to grow a community culture. This journey needs to be experienced just like the perfect sunset, by relieving suffering and improving the quality of living and dying. Our palliative care pathway was created to improve our patients' life.
So this concludes my portion of the talk. I really wanted to thank all my team members who have actually helped me put together, especially the last part of this presentation. And I also wanted to thank all of you for attending this talk. More importantly, I want to thank all of you for all that you do, because I know that you are making a huge difference for the people around you during this pandemic. Thanks.
Thank you, Christine.